So my name's Simon Pearce, and I'm a consultant up in Newcastle in the northeast. I'm going to talk today about the best treatment for hypothyroidism. This is probably the first of two talks on this subject, and today I'm going to try and cover what are the symptoms of hypothyroidism, how do we test for it, and treatment with levothyroxine. And there'll be quite a lot of detail here, and hopefully in a later talk I'll talk about some other issues. So when we talk about hypothyroidism, there are a variety of reasons you might have hypothyroidism. Some people are born without a thyroid gland, that's called congenital hypothyroidism. In some cases it's taken out by a surgeon. A few drugs cause hypothyroidism, and some people get treated either for thyroid overactivity or thyroid cancer with radioiodine or a few other conditions in which your neck becomes irradiated. But the overwhelming commonest cause of hypothyroidism is Hashimoto thyroiditis, and this is where the body's immune system attacks the thyroid and gradually eats the thyroid away so it disappears over time. And often the first sign of this is these positive thyroid peroxidase or TPO antibodies in the blood. And many people will have positive antibodies but normal thyroid tests, and then gradually over time they develop hypothyroidism. So if you're in this situation, either you've got positive antibodies or sometimes it's even detected on a thyroid ultrasound scan. About 5% a year will develop hypothyroidism, but many people remain in this compensated state without hypothyroidism, where the thyroid gland is being attacked, but your thyroid function is maintaining itself for many, many years. So if we follow people in this situation for 20 years, only about half will have developed actual hypothyroidism by the end of that time. So moving on to the symptoms of hypothyroidism. This is an excellent study, the Colorado Health Fair study, where 25,000 people attended a health fair, which is a way of people getting free healthcare in the US where you have to pay for everything. And they filled out a detailed questionnaire about thyroid symptoms, and then they had a blood test. About 22,000 people were euthyroid. That means their thyroid tests were normal, euthyroid. But round about 2,500 were either subclinically hypothyroid or who had frank hypothyroidism, thyroid underactivity. And these are the typical symptoms that you might be familiar with if you suffer from hypothyroidism: poorer memory, slower thinking, weaker muscles, more tired, and then a variety of other things that they asked about. And you can see that, say, for the top one, a dry skin, people who are euthyroid with normal tests, well, maybe about 25% of them were complaining of a dry skin, and it goes up to about 27-28% in people who are hypothyroid. And that's similar for all of these things, and that many people who had normal tests also complained of the same symptoms. In fact, if deepening voice is often a feature of hypothyroidism, but in fact, if you said, my voice is deep now, actually more healthy people with normal tests complain of a deep voice than people with hypothyroidism. But a change in voice, my voice has gone deeper, there's a slight change towards hypothyroidism. So these symptoms are very non-specific, and there are lots of other reasons why people might feel their voices have changed. So when we look at the symptom burden, how many symptoms did people have? 0, 1, 2, 3, or 4 or more? And the euthyroid people, that's the people with no thyroid problem, in the white boxes, and then subclinical or overtly hypothyroid in the other boxes. So you can see for people with more than 4 symptoms of hypothyroidism, about 25% of people who had 4 or more symptoms had hypothyroidism, as compared to maybe about 18% who had normal thyroid tests. So there's definitely a thing going on there, it's worse. But for people with 2 symptoms, there's absolutely no discrimination. But if we look at people with 0 symptoms, this is in some ways the most interesting part of the study. For people who had normal thyroid tests there, 40% of them had no symptoms of hypothyroidism. That means when we add the bars of people with normal thyroid tests with 1, 2, 3, or 4 or more symptoms, that 60% of healthy people have at least one symptom of hypothyroidism, irrespective of the fact they don't have thyroid disease. So this is quite an important finding, because it reflects how we deal with thyroid disease symptoms in real life. So this is just a similar study from Denmark, apart from much smaller, 140 patients with overt hypothyroidism, and then they matched 4 healthy people with normal thyroid tests for each one with hypothyroidism, and they just stratified them by age, so less than 30, 30 to 40, 40 to 50, etc., and then the last thing over 70. And these are just the number of symptoms, okay? So if you're less than 30 or 30 to 40, on average you have about 6 symptoms of hypothyroidism when you're diagnosed. But by the time you're 70, you've only got about 3 symptoms or 3.5 symptoms of hypothyroidism when you're diagnosed. So older people tend to have fewer symptoms than younger people. And particularly over the age of 50, it starts to drop. But once again, the healthy controls, they don't have no symptoms. On average, the healthy controls throughout the whole age range have between 2 and 3 symptoms. So this is exactly what the other study shows. People with normal thyroid tests have hypothyroid symptoms. So what we learn from these studies is that symptoms of hypothyroidism are not really that specific for thyroid disease. They're common in people without thyroid problems, and that older people tend to have fewer symptoms. So moving on to thyroid testing, I just need to help you understand a bit about what the tests mean and where they all come from. So this is a little diagram of the thyroid system in your body. The hypothalamus is a special part of the brain which is responsible for sensing all the hormone levels that are going to your brain, and the brain uses the hypothalamus to tell the body how to make its hormones. So the hypothalamus secretes this little peptide hormone, TRH, which stimulates the pituitary gland to make TSH. Okay, TSH stands for thyroid stimulating hormone or thyrotropin, thyroid stimulating hormone. I'm going to hear a lot about TSH in the rest of the talk. So the TSH gets carried in the bloodstream to the thyroid, and it stimulates the thyroid to make the thyroid hormones T4 and T3. That's thyroxine or triiodothyronine. And these then circulate back around the body and go back up to the brain, both the pituitary and the hypothalamus, and then that tells the brain there's enough hormone now in the body and it can stop making TSH, and so it stops making TRH. And so that's called the negative feedback loop. The presence of these hormones in the blood is sensed by the brain, and it either tells the thyroid to make more or make less of these hormones. So the key things we measure when we're looking for hypothyroidism are TSH, thyroid stimulating hormone, and also T4 in the blood. So we measure that as free T4 or free thyroxine. So firstly, we need to understand TSH is not a straight line in the blood. So there's a diurnal secretion of TSH from the pituitary, and it goes up at night. So there's a peak around about 2 o'clock in the morning when we're asleep, and then it gradually falls from that to a trough around about 2 o'clock in the afternoon, so just in time for a late lunch. And so some people will have their blood tests done several times over several years, and they'll say, well, when my GP's measured it, half the time it's normal, and that's probably when you've had it measured in the afternoon or late morning, and then when it's measured first thing in the morning, though, the TSH can be slightly high, and the GP may be thinking you've got mild hypothyroidism. And so this is why sometimes people's thyroid tests seem to change when in fact there's nothing really changing, because there is this change in TSH over time. The average TSH in population, in almost every population, is between 1.6 and 1.8. It does vary slightly depending on, obviously, the method used to measure it, but also on the iodine intake of the population, and also probably as you grow older, as the population ages. So if you looked at 80-year-old people, it would probably be a little bit higher towards the 1.8, maybe from 1.9 levels, but it rarely goes over 2 in whatever population you're looking at. TSH also varies by season. So this is a great study of hundreds of thousands of biochemical tests taken over 6 years from a Japanese hospital. And you can see that there's a trough in TSH levels in June and July. And then by Christmas, your TSH is higher again. And so even with all other things being equal, you're more likely to get diagnosed as having hypothyroidism with a high TSH at Christmas time than you are in June. There's not much in it, but if it's a borderline measurement, that's definitely the case. So to decide whether a thyroid hormone test is normal or not, we use reference ranges which are derived from studying 1,000 healthy people who we don't think have got thyroid problems. And so TSH, thyroid stimulating hormone, the reference range is 0.3 to 4.5, and that's in millunits per litre, and that's a constant measurement throughout the whole world. Everyone measures TSH in millunits per litre. The amount of thyroxine in the blood is normally measured by free thyroxine, or free T4, FT4, and the range is 10 to 22. That's measured mostly in Europe in picomoles per litre, but in some healthcare systems it's measured in nanograms per decilitre, and the values are roughly tenfold less. So it's about 0.9 to 2, I think, is the normal free T4 measurement in nanograms. So if you're becoming hypothyroid, what happens is, first of all, the brain is telling the pituitary to make TSH, and it's sending a signal to the thyroid it needs more thyroid hormone. So the TSH starts to go up. Okay, so TSH is the brain signal, and the brain is saying, the body's I need more thyroid hormone, please make some more. And so it's stimulating the thyroid, and this level goes up, and then and that's the first change almost always. And then the free T4 level, the thyroxine level in the blood, starts to drop and goes below 10, so it goes to 9 or 8 or 7. And that's the pattern you'd expect in hypothyroidism. So I've got free T3 on there as well. That's the amount of T3 in the blood, and that's the reference range for T3. But T3 is not a really very good marker of hypothyroidism. And that's because it's normal in people, sometimes even with very severe hypothyroidism. So we don't recommend measuring T3 in someone who you think might have hypothyroidism because it doesn't reflect the tissue T3. And as I said, it's normal in many patients with profound hypothyroidism. So T3 is a very labile hormone, meaning it's unstable in the blood. So if you miss a couple of meals and you're fasting, Ramadan, you'll have a low free T3 at the end of that. And free T3 can be reduced by any significant illness. So I often teach my junior doctors the place in the hospital to go with where everyone has a low free T3 is the intensive care units. The critical care patients all have low T3s because they've got lots of bad disease, and bad disease causes your T3 to drop in the blood. Probably the T3 is going into the tissues and staying there and doing its job, but it's just in the blood. The body's stopped making a lot of it because it's excess, because it's not needed. And so even in people who don't have critical care illnesses, just an infection like a bad common cold or the flu, pneumonia, a urine infection, that would be enough to drop your free T3. And so we occasionally see that someone who's had their free T3 measured in the thyroid clinic, and actually it's a bit low, all their other thyroid tests are normal, and then the reason is because they've got a cold or they've got the flu. Certainly COVID drops your, having acute COVID drops your free T3. And any inflammatory illness, so an inflammatory arthritis, rheumatoid arthritis, or cancer will also drop your free T3. So free T3 tells you there's something wrong with the patient if it's low, but it doesn't tell you what's wrong, and it doesn't mean there's anything wrong with their thyroid. So that's why we don't measure it. So how do we diagnose hypothyroidism? So the best test is serum TSH, and if it's over 10, the person has hypothyroidism, and we'd recommend repeating it once and then treating the person with levothyroxine. If the serum TSH is in this grey area between 4.5 and 10, it's elevated, but it's not very high, but the free T4 is low. That's also hypothyroidism because the free T4 has gone down. And the same again, we repeat and treat. And the reason we do the repeating and treating is because we're going to treat someone for life, for the rest of their lives. Lifelong treatment is expected. And as there's a bit of variability about TSH, we want to make sure that we're not treating them for the wrong reason and that they just had a one-off abnormal blood test. So we'd always repeat it before we start lifelong treatment. Now, if the TSH is lower, between 4 and 10, but the free T4 is normal, then this is subclinical hypothyroidism. It doesn't mean the patient doesn't have symptoms necessarily, but it means the symptoms might not get better if we treat. So we definitely repeat after an interval, and I'll show you in a few more slides that this is often a transient situation and it recovers, because any illness, such as a bad flu or COVID, the TSH will rise for a week or two afterwards in recovery. So in older people, we would be really hesitant to treat this. We'd mainly observe. We might consider treatment in younger people, but many people have no symptoms. And I'll show you a few studies about subclinical hypothyroidism in a few more slides. So sometimes people have lots of hypothyroid symptoms, but they have normal thyroid tests, and they say, surely I've got a thyroid problem, doc, I've got problems with my weight management, I've got brain fog, I feel very fatigued, I'm really exhausted, I've got constipation. I don't care that my thyroid tests are normal, I should have some thyroxine, I'm sure I've got hypothyroidism. So it's an interesting situation, and amazingly, about 20 years ago, they got this study past the ethics committee, and they decided they were going to treat these patients with thyroxine. They had symptoms of hypothyroidism, but thyroid function tests which were within the reference range. And they did this double-blind crossover trial, which means every patient in the trial had a period of time taking thyroxine and then a period of time taking placebo, and to see if they felt better on the thyroxine. And these trials are quite complicated to analyse, but the p-value, that's the probability of this result occurring by chance. And so a low probability value means a significant, important result. And in fact, all these probability values are, so the highest you can get to is 1 for a probability value. So all these are occurring by chance. There's no difference between symptoms in people who are treated with thyroxine or being treated with placebo. So this study really shows having normal thyroid tests predicts that you won't feel better when you're treated with levothyroxine, whatever your symptoms. So that's an important piece of information for us to think about. So levothyroxine treatment, well, we normally recommend starting a full replacement dose depending on your body weight, and the exceptions will be people with known heart disease or people who are really quite old. The formula is 1.6 micrograms of levothyroxine per kilogram of weight. So for instance, if you're 50 kilos in weight, your thyroxine dose should be about 75 micrograms. If you're 60 kilos, 100, 75 kilos, 125, going right the way up to, if you're 125 kilos, 200 micrograms of levothyroxine a day. If you're 150 kilos, you may need to go up to 250 micrograms a day. But of course, a lot of people fall in the gap here. Some people might be 68 kilos, for instance, and then it's quite fine to take 100 micrograms one day, and then 125 micrograms the next day, and then 100 micrograms the day after, because it's the average dose that matters. And this is because levothyroxine has a long half-life, okay? The half-life in the blood is about 7 days. And that's also one of the reasons it's easy to forget to take your levothyroxine. Because if you miss out a dose, you don't feel any different because you've still got this big reservoir because of the long half-life in your blood. A few drugs prevent absorption of levothyroxine. That's calcium salts, either calcium or something like Reni, iron tablets, omeprazole, lansoprazole, PPI, that's stands for proton pump inhibitors, all drugs of that class ending in prozole have this effect, gaviscon. And this is because you need acid in your stomach to absorb the levothyroxine, and these drugs all stop the acid or neutralize the acid in your stomach, so it makes it difficult for you to absorb levothyroxine. A few other people have a problem with their stomachs causing malabsorption. That would either be celiac disease, which is another autoimmune disease, or atrophic gastritis, also known as pernicious anemia in its later stages. And these people don't really have any acid in their stomach, which is why they can't absorb the thyroxine. And if you treat someone with hypothyroidism, often the TSH takes 3 to 6 months to normalise. And actually, it turns out there's no rush to get the test normal. So this is a nice study of the starting dose of levothyroxine in primary hypothyroidism. And two groups of patients, one group was started a full dose depending on their body weight, and then another group was started on a low dose, 25 micrograms, and it was increased every 4 weeks until they were on the same dose. So you can see here the TSH drops rapidly in the full dose group, and it stays flat, and then they converge about 16 or 20 weeks. But people on the low dose, it takes longer for them for the TSH to normalise. At the free T4 level, similarly, people on the full dose, they get to normal free T4 within 4 weeks, but people on the lower dose, it actually takes 16 weeks to reach a normal free T4. But what's most interesting is that the symptoms, this is a clinical score based on how many symptoms they had, they all start off with a load of symptoms. Symptoms don't really fully normalise till 16, 20, 24 weeks in this study, but there's absolutely no difference in how quickly these people take to feel better. So it doesn't matter if you start on a low dose or on a full dose symptom-wise. It does mean more effort having repeated blood tests and so forth, but you still feel better within 4 weeks, identically as if you're on full dose treatment, even if you get started off on rather a low dose, which is interesting. So I'm going to talk about dose effects as well. This is just a little map of time over the course of the day, and this is the reference range for serum free T4 here, between 10 and 22. That's what this box is. And the red line represents your serum free T4, your thyroxine level. So you wake up in the morning, maybe 6:30, and you take your tablet at 7 o'clock, levothyroxine 100 micrograms, and what happens is the amount of levothyroxine in your blood increases quite rapidly, and it gives you a little peak which is present for 2, 3, 4 hours, and then it drops back into the normal range, and then slightly dips over the course of the day, but it's pretty constant after that until the next day. So that's all very well and not a problem there at all, having this little 2 or 3 or 4 hour interval in the day when your serum free T4 is above the range, because it's actually in the normal range for the whole rest of the day. That's fine, except if you go to your GP and you have a blood test. So what happens is you take thyroxine, say 7:30, you have a blood test 9:30, okay, and you're in the middle of this peak. And this is what your thyroid function tests show. TSH, absolutely normal, 0.9, it's perfectly in the reference range, an ideal TSH. But your free T4 now is a bit above the reference range, and your GP looks at these blood tests and says, actually, your free T4 is a bit high, you should reduce your levothyroxine dose. And you don't need to reduce your levothyroxine dose. So the recommendation is, if you're going to have free T4 measured, which you don't have to really, unless you've got a pituitary problem, which would mean TSH is unreliable, but if you're going to have free T4 measured, then it's best to not take your thyroxine on the day of your thyroid test till after you've had the blood test done, because you get this problem. And I've seen this numerous times, literally 1,000 times. People have had their thyroxine levels reduced on the basis of a normal TSH and a minimally high free T4 caused by this little dose effect in the mornings. So avoid that. So should you always take your levothyroxine in the morning, or is it okay to take it in the evening? This is a really nice crossover study again with 90 patients who had hypothyroidisms. This was a 12-week crossover trial, so they had 12 weeks on each treatment. And it turns out the patients who took their thyroxine, at the time they took their thyroxine at bedtime, their TSH was a bit lower. Okay, so that means more thyroxine was absorbed into their body if they took the thyroxine at bedtime. And there was no difference in the quality of life or how they felt, but there's this difference here, 1.25 millunits lower in patients who took bedtime thyroxine. So we would recommend actually either taking your thyroxine first thing in the morning or an empty stomach, or if that's difficult for you, if you're rushing in the morning and you don't have time. A lot of people, particularly like me, I'm always rushing in the morning. I really bulk my breakfast. This is a good thing to do, take thyroxine at bedtime. And then how do symptoms go? So you had a talk already from Talk Will What, a few months ago. But this just shows treatment in 79 people with newly diagnosed hypothyroidism, and this is Torquil's ThyPro scores. So this is The general population in blue, that's how they feel on this scale, and then people with autoimmune hypothyroidism in the orange, and then 6 months later on thyroxine treatment in the green. Okay, so tiredness improves over 6 months, but doesn't quite get back to the normal range. Hypothyroid symptoms, they definitely improve, but not quite to the normal range. Hyperthyroid symptoms, same, they actually improve. Overall quality of life really improves a lot, but it's probably not back to normal. And so for all these things, levothyroxine helps you and it improves symptoms, but there's still a bit of a gap between people feeling absolutely normal and between people who are receiving treatment for the hypothyroidism with levothyroxine and feeling 100% normal. So, to summarise, taking levothyroxine, take it morning or evening, definitely on an empty stomach though. If you have variable serum TSH levels, consider the time of day you take the tablet in relationship to the time of your blood test, because that could explain it. Don't take your levothyroxine on the day of your blood test, and try to have your TSH measured roughly at the same time of day to get comparative measurements. For people with a lot of variability, it's a good idea to stick to one levothyroxine brand. I used to prescribe altroxin, but now that's not available. Just prescribe. You can choose whichever one you feel best on, Almus or Teva or any of the makes. If you feel good on that, just ask your pharmacist to keep supplying you with that. And the MHRA, that's the government drug authority, have now issued, about a month ago, issued guidance to say that people who feel variable symptoms on different brands should be allowed to stick to the same generic brand of levothyroxine. So you just need to ask your pharmacy, and you can go to the MHRA website and print out the information if they don't believe you. Another little tip is, because you need acid in your stomach to absorb the levothyroxine, if you think it's variable or it's not getting in, take it with some citrus juice, some orange juice, some kind of fruit juice, or you can take it with half a vitamin C tablet as well, because that's an acidic thing. Ascorbic acid in the vitamin C will help you absorb it. There's absolutely no harm in doing that, and that can sometimes have quite dramatic results in people on quite high doses of levothyroxine because it's not getting in. Avoid all these other tablets. Calciums, Calcichew for osteoporosis or Rennie for indigestion. Basically almost anything for indigestion is bad. Iron tablets, proton pump inhibitors, that's the lansoprazole, omeprazole, Gaviscon, and then colsevolam and cholestyramine. These are treatments that we actually give to patients to stop them if they overdose on thyroxine, to get it out of their systems. So definitely that has an effect if you're taking those drugs. So I'm going to talk for a couple of slides now about subclinical hypothyroidism and then finish up. So subclinical hypothyroidism is a state where the TSH is a bit elevated between 4.5 and 10, but the free thyroxine in the blood is still normal. So first of all, what does this mean? So this is a paper from Israel actually, and they took data from nearly 500,000 patients, 422,000, who had thyroid tests in primary care, and about 3%, 12,800, had a TSH in the subclinical hypothyroidism range, 5.5 to 10, equaling subclinical hypothyroidism. And all they simply did was look at their next blood test after they had this abnormal blood test, TSH between 5 and 10. What they found was in about 30%, the TSH remained between 5 and 10. In about 2%, it got worse. They went to overt hypothyroidism with the TSH greater than 10, but the majority, 62%, the TSH normalised and went back into normal range. So that means subclinical hypothyroidism, the first thing to do is absolutely nothing except to repeat the test in, say, 3 months' time, because most people will have normalised, 62% will have normalised the TSH in 3 months. And certainly you should not rush into treating this because it's likely to go away of its own accord. So should you treat it with levothyroxine? So this is a study in older people from a variety of countries, Switzerland, Holland, Ireland, Scotland. And they recruited people around about the age of 75, about 370 in each group, and they gave half placebo and half levothyroxine. TSH before treatment was about 6.3, or 6.4, so it's in the subclinical hypothyroidism range. And what they found was this: they looked for hypothyroid symptoms and tiredness scores, and basically the group who received levothyroxine no change a year later. The group who received a placebo, also no change a year later. So there's no significant benefit of giving levothyroxine, certainly to people aged 75 or not. This study, called the Trust study, has been widely criticised, and I'm one of its critics. One of the reasons is they really gave quite a small dose of levothyroxine, 50 micrograms a day, which we wouldn't consider a full replacement dose. So, and of course, this is people who are 75. Whether this has any relevance to people who are aged 35 or not is a big issue. So what we do see, though, this is Peter Taylor's study. This was a study of the average TSH concentration in the UK at which people get prescribed levothyroxine between 2001 and 2009. So it dropped from 8.7 to 7.9, so it's dropping over time, the average TSH at which people get prescribed levothyroxine, and that might not be a good thing because for most people with TSH of less than 10, they probably won't feel better for this treatment. Similar studies just been published from the United States literally 2 weeks ago. 110,000 people started on levothyroxine for the first time between 2008 and 2018, so a 10-year period. The average serum TSH was 5.3, same reference range that we've been using all along, so it's just very mildly high. 60% of them were treated for subclinical hypothyroidism, when we know that's quite likely to get better of its own accord, in fact in 60% of the cases. 12% were treated for overt hypothyroidism, or a TSH of 10 or more, which is absolutely fine. Those are the people who we think need treatment. But crazily, 28% were treated with a normal serum TSH and free T4. And I've already shown you the randomized trial that shows if you've got a normal serum TSH and normal serum free T4, treating with thyroxine does not improve your symptoms. But this is nearly a third of people taking levothyroxine in the USA were treated over this period of time with no abnormalities of their thyroid tests. So this is a really crazy situation. This just shows you the graph here. So this is over time, year by year, and these are the people with normal thyroid tests at the top. And actually it hasn't got better or worse over time, it's approximately the same. And these are the people with subclinical hypothyroidism as well, and that's pretty much stationary over time. So this is interesting, but there are probably a lot of people out there with subclinical hypothyroidism who don't need to be treated, and they could feel absolutely fine on no thyroxine at all. So subclinical hypothyroidism, many people are treated with the TSH values in the 5 to 10 range. They never had hypothyroidism. If you stop the thyroxine or just observe them to start with, it would have gone away. We do recommend a repeat serum TSH in 3 to 6 months, but if you're pregnant or about to try and fall pregnant, then we would definitely recommend treatment. So in almost all cases of subclinical hypothyroidism, it's observation, except in the case of pregnancy, which is a special situation, and we know both the mothers and babies do worse in pregnancy if there's subclinical hypothyroidism. So in a young patient with subclinical hypothyroidism with a persistent abnormal TSH for 3 months or 6 months preferably, and clear symptoms, then I would say, yeah, it's worth a trial of treatment for these people, particularly someone less than 40. But in older age groups, the evidence for benefit is really not there. And there's another trial that shows the same as the Trust study, that for older patients over 65 or 75, then there's not really any evidence for treatment. And in fact, levothyroxine may even be a bad thing for older people. So many patients with a TSH of 5 to 10 have a transient abnormality. They don't have symptoms caused by hypothyroidism. Most people without a thyroid problem have 1 or 2 hypothyroid symptoms. And the TSH threshold for intervention is dropping. And that may not be appropriate. We're probably over-treating people who don't have thyroid problems at the moment in the US particularly, but probably also in the UK to a lesser degree. So those things I've talked about today. What are the symptoms of hypothyroidism? How do we test for hypothyroidism? And treatment with levothyroxine. My talk could go on for another hour and deal with some other things, but I'm going to do that at another time. And I'll take your questions now. I'm really happy to talk about anything you want. But spoiler alert, the next episode is going to talk about thyroid bias, which we haven't really talked about today, and also treatment with T3 and T4 combined therapy, So maybe we should focus our questions today on levothyroxine, because that's the common situation for most people. And then we'll deal with these other things at another time. So thank you for your attention.
Great, thank you, Simon. Such a lot of information there, and such a lot of different studies shared. I guess a lot of the patients in the room were a bit of a self-selecting group, people who are interested in thyroid talks. You know, we're maybe not so much the average patient, and it's you know, for example, I was diagnosed with subclinical hypothyroidism, and when I was initially started on a very low dose, I actually became very much more unwell, and I've had to have a very fine-tuned treatment to get myself back to a reasonable state of well-being. And you know, where would you, as a clinician, given the evidence base that you have, which, as you said, is quite scant, you know, where would you make the decision onto, you know, when you've got a patient in front of you who really does need a fine-tuned dose, for example, or who does need to be treated if their blood tests are unclear? You know, what guides you in making those decisions and helping people who are having a lot of symptoms, which may or may not be caused by hypothyroidism?
Well, I think you have to have a flexible approach. You know, you can't say I always do this, because you know, you have to use your experience, use knowledge of the trials, and put it in the context of an individual. Because if medicine wasn't about treating individuals, robots would be doing it, and doctors would be unemployed, probably. Yeah. So I think you have to take into context the person's symptoms, how likely you think those are to be caused by an abnormal thyroid function tests. So there are two. Another thing to take into account is, do I really think this person has a thyroid disease? You know, what thyroid disease am I treating is often a question that goes through my mind, because some patients, there's something in the chat about this actually, some patients clearly have antibodies, so you can say this person's definitely got Hashimoto's thyroiditis. The question is, do they need treating, and do they need treating now? Because we know, even if you leave people for 20 years with positive antibodies but a normal TSH, only half of them will develop a high TSH over 20 years. So,
and if they're feeling very unwell during that time, then you know, perhaps they need intervention. But if they're actually feeling completely fine, then why would you?
Yeah, exactly right. And so I think for me in this situation, it's a trial of therapy, and you know, I think people should have a reasonable dose of treatment. You know, like not give them 25 or 50 micrograms, but probably more like give them 100 micrograms, so they're properly treated. Do it for 4 or 6 months, make sure their tests bang in the normal range, and then if they feel better, brilliant. If they don't feel better, I would stop the treatment and then see how they feel, because they may not feel worse off treatment than they felt on treatment. You know, and so the symptom response I'm looking for is for someone to feel obviously better when they start treatment. But if they don't feel obviously better when they start treatment, I also want to know that they don't feel worse when they stop treatment. You see what I mean?
You know, and you've got to treat people as individuals, as you say. And I think that's something that probably everyone in the room really could have needed to hear, because a lot of us are perhaps particularly tricky patients to treat, and that's really heartening to know that you know, that is, you know, how doctors are approaching things. I just wanted to say one other thing about the presentation before I make just a few little announcements, and then we have just a little 5-minute break and then come back, and then that gives you time, Simon, to have a bit of a scan of the questions that have been coming in, and gives us all a chance to think a bit more as well. So you mentioned in the talk, you know, we don't recommend testing for T3. And I thought I probably ought to just flag up that obviously that T3 treatment is a controversial area. And you're going to talk a lot more about it in part 2 of this presentation. But I think it's just worth, you know, people in the room being aware doctors don't necessarily all agree on this, and it is a controversial area. There isn't a sort of medical consensus, you know, what one doctor might decide to do and think is useful is not necessarily the same as another one. Would you say that's probably about right?
Well, I think whether to treat with T3 is a controversial area.
Yeah.
whether you should measure T3 in hypothyroidism, I don't see that as being controversial, because it's not a helpful test. You know, if you decided not to treat people for hypothyroidism on the basis they had a normal T3, you would not treat 50 or 60 or 70% of people with hypothyroidism, because you can have absolutely profound hypothyroidism with a TSH of 100, you know, really, and a really low free thyroxine value, but still have a normal T3, because your body wants to put every last molecule of thyroid hormone into T3, and so you have a whole homeostatic mechanism to preserve T3 in the blood in the case of gradual onset hypothyroidism. The enzymes that convert thyroxine to T3 kick in more, and they convert relatively more of your thyroxine to T3, and so you get these patients in iodine deficient areas will have a high TSH, often an enormous thyroid, but if you measured their TSH would be high. If you measured their blood T3, it's probably normal.
And it's just their body working so hard to get them that, because that's what they need.
So many times T3 is a red herring when it comes to the diagnosis of hypothyroidism, that it doesn't give me valuable information, because in medicine a test has to really tell me something that nothing else does to make a decision. There's no point in measuring something if you're going to say, well, it doesn't matter whether that's normal or abnormal, I'm going to treat this person anyway. So that's why I don't measure T3 in patients with hypothyroidism, because it's not going to sway my judgment one way or another. And to be honest, people in my thyroid clinic get it measured anyway. We just look at it and we'd go, well, it's not going to make any difference to our decision here.
I guess that's the thing. In some cases it is measured, but in terms of how you actually use it, perhaps it's not that useful. Thank you for that. I'm just going to make a couple of announcements then, if that's okay. First of all, to say, I've said already, part 2 of this talk is the 15th of September at the same time, so put that date in your diary, please. Before then, we're going to have an informal thyroid cafe session. So we won't have a speaker, we'll just have a drop-in session for patients who want to meet other patients, and that's being hosted very kindly by our trustee, Karen George, who has Graves' disease, on the 7th of August. We're doing it at 11 o'clock because we have our thyroid cafe sessions at 11 as a sort of 11sies type session. If people are interested in that, it would be really delighted to see you there. And then on the 11th of September, Judith, who's hosting today with me, who has had thyroid cancer twice, is going to host a thyroid cafe. So for anyone who has experience of thyroid cancer, and that could be if there's somebody that you know who's got it, or someone in your life has had it, as well as you yourself personally, or indeed if you're an interested professional, you're welcome to drop into that session. So that will be on the 11th of September at 11 o'clock. Also, just to say on the topic of hypothyroidism, I know it's a bit frustrating that today we're having effectively half a talk. As Simon said, he could have easily spoken for another hour on the subject. If you're interested in seeing what some other doctors have to say on the subject, you can obviously have a look at the information videos that we've got of previous talks on this subject, and you'll see different people take different approaches. And then Simon also very kindly mentioned a previous talk that we'd had at one of our events from Torquil Watt, who developed the quality of life measurement tool for thyroid patients. And the video of that talk is also on our website. You can find it also on our YouTube channel. So if you're looking for our information videos, go to the website, information section, information videos, and all the talks are on there. So that's all my announcements. Should we just take 5 minutes and come back at 6:57 on the dot and start going through some of the questions? We'll see you all in 5. Thank you.
Vitamin C. If you start taking something acidic like vitamin C, then you can often start to absorb a lot more of your thyroxine dose, and your TSH can plummet dramatically like that. So yeah, so that's a common experience. Shireen says, medical practice.
Could I just butt in, Simon? There was another vitamin C question.
Okay, yeah.
From Emma, so I thought you might like to deal with that at the same time. Emma says, would you recommend a soluble vitamin C tablet or just one you swallow?
I don't think it makes any difference at all.
Yeah.
And you know, you can buy like 1,000 milligram vitamin C tablets, the large fizzy ones. To get the right amount of acid in your stomach, you can take half or a quarter of one of those, and it works just as well. So I don't think it makes any difference. Just whatever you feel comfortable taking will be fine.
And just to say on Tracy's question, she mentions that she saw a presentation from Mark Gurnell at Addenbrooke's talking about the antibodies and PowerPoint presentation, and he said that he thought TSH would rise in response to T4 and T3 antibodies. I'm not sure what antibodies she means there.
Yes, I'm not very sure about that either. It's not antibodies to T4 and T3 are documented in people's blood, but they're incredibly rare. So this isn't a common thing. And antibodies to the hormones are mainly an analytical problem for the laboratory, and they can sometimes stop the laboratory measuring the right levels, even though the person's levels are okay.
Right, well, because they interfere with the...
they interfere with the measurements.
Interesting. But you think it makes absolute sense that because she's taking the vitamin C things, that would absolutely cause the TSH to plummet? And the
absolutely, yeah. I've seen this on numerous occasions. People with a high TSH taking thyroxine, and they've probably got some mild so-called atrophic gastritis, or and they're not making enough acid for a different reason. And you often I swap the thyroxine dose to bedtime and add in half a vitamin C tablet, just 50 milligrams or so, and that's enough to
makes a huge difference.
Make a huge difference, yeah.
Yeah, isn't that interesting? Really interesting. Thank you. So have you come to Shireen's got two questions, hasn't she? Take the second one first, maybe. Do you believe and have you heard of people reversing hypothyroidism, and what are your thoughts on this?
Well, I mean, we in the UK and in the Western world, we don't tend to think of that very much, but in Japan, they routinely stop people's replacement therapy after a few years, and they say 50% of people reverse their hypothyroidism.
Wow.
So there's a recent study out this year from America, actually the same group who did that study with the levothyroxine, which showed for patients who don't have a very clear-cut diagnosis of severe hypothyroidism, if you stop their levothyroxine, you can have about 30% of people will not need it ongoing. So 30% of people may have either been, I mean, this is the problem about the American healthcare system, is sometimes it's difficult to get to the bottom of it, because the same group have just shown 30% of people had normal thyroid tests when they started treatment. But those 30, if you're on levothyroxine and you stop it, there is a chance that your thyroid can be normal. It may not be as much as 30% in the UK, but it's probably, it's certainly 20%, and that'll be 50% of people who their thyroid disease has maybe improved spontaneously. And 50% of people, they didn't really have serious thyroid condition in the first place, and it was going back to normal of its own accord. So I mean, that's a really unexplored area, but there's very clearly, and sometimes my advice to people who I see who don't feel well on levothyroxine, and sometimes people have been on it for 10 or 15 or 20 years, and the past about why they got started on it is really murky, and you can't get the information. And sometimes I just say, well, we don't have much to lose. Why don't you just stop it, and we'll recheck your thyroid levels in a month and see how you feel. And people have been, I've had someone who's been on, a 50-year-old lady who was started on levothyroxine as a teenager, and we couldn't get the old records. but she didn't feel well. And I said, well, why don't we just stop it? There's nothing obvious, going on. And her thyroid test remained normal. So.
And did she feel better not taking it?
Yeah, well, she'd been taking it all her life and feeling a bit anxious and on edge.
Yeah.
So, yeah, so it's interesting. And, what do you lose? You lose, I mean, most people, this is one of the great things about thyroid hormone levels is your body is so well adapted to keep your thyroid hormone levels normal, is that people think, well, I had a bad day because my thyroid levels had a bad day. Actually, your thyroid levels are very stable. They don't change day to day. So people who have a bad day and then a good day, that almost tells me it's not their thyroid, because except in very rare cases, your thyroid doesn't move that fast. Your levels are stable over a week or two. You can definitely have a bad month or a bad 6 months because of your thyroid, but you don't have a bad day. And similarly, if you stop your levothyroxine, you're not going to feel bad the next day. You might start to feel bad 10, 14 days later as the levels gradually decrease. So it's quite a safe thing to do. And as long as you've got a backup program that you're going to measure, recheck the thyroid hormone levels in 4 to 6 weeks, that's absolutely fine. And some people will get a bonus that they won't need to take this stuff for the rest of their life, which is fantastic.
That's extraordinary. It'd be an interesting thing to see more research into. On the question of how long your thyroid hormones stay stable for and how long T4 is active in your body, I saw somebody in the chat asking, is it right that T4 stays in your body? I think they said 6 days.
6 days, yeah. Well, that's the half-life is 6 to 7 days in most people. And so that means, if you take 100 microgram tablet, 50 micrograms of it is still in your body at 7 days, and at 14 days, 25 micrograms is still in your body, and at 21 days, 12.5 micrograms of that same tablet is still in your body. So that's the way the half-life kind of decays. And of course, you take it every day, and so you've got this reservoir which is constantly topped up by what you're taking, if you like. But it's so it is very stable, and 6 days is the average for most people.
Again, that's what I was going to ask, is does it vary from person to person sometimes?
There's probably a minor variation, right. Probably depending on kidney function, I would guess, but it's not it's not a huge variation.
Yeah. And on this thing about people sometimes reversing hypothyroidism, Michael Bond asked a question in the chat. He was saying, does cortisol have a role in relation to thyroid hormone function? And I picked up on that because I was talking to somebody recently who was telling me that through practicing lots of stress reduction techniques, that she had actually been able to quite radically reduce her levothyroxine. So I wondered if you had anything to say on the cortisol.
Yeah, so cortisol, if you've got cortisol deficiency because of an adrenal problem or a pituitary problem, and you don't take your cortisol replacement, that will affect your TSH quite markedly. So if you're cortisol deficient, your TSH goes up. But otherwise, cortisol and thyroid are regulated fairly independently. The other thing we really occasionally see, but we're quite sensitive to it, is someone feels absolutely wiped out, tired, and they come with a high TSH, and we treat them for hypothyroidism and they feel worse. And that can sometimes indicate they've got coexisting adrenal insufficiency. And so we have a low threshold for testing people like that for adrenal insufficiency, because thyroid hormones, if you've got untreated adrenal insufficiency, definitely make you feel worse rather than better.
Right.
There are a number of other questions on drug interactions. So I wonder if it would be a good idea if we take a look at those next, following the cortisol question. Mercedes wants to know, can heparin affect the thyroid? Can the contraceptive pill affect it? And can warfarin affect it?
Yeah. So those are good questions. Heparin displaces thyroid hormone from the carrier proteins in the blood. So when you start on heparin, you probably see a little peak of free T4 increasing in the blood, and then that goes back to normal. So we certainly see this in hospital occasionally. Someone who's heparinized who has a highish free T4 in the blood, but normal TSH, and that's just an effect of heparin knocks thyroid hormone off albumin, which is how it's carried in, or partly how it's carried in the blood. So there is a small effect of heparin, but the TSH is almost always normal in that situation. It's not an actual thyroid disease, it's just an effect on the carriage of thyroid hormones in the blood. Warfarin, if you increase your thyroxine dose, you'll probably metabolize warfarin quicker. So you'll need a higher dose of warfarin to maintain the same degree of anticoagulation. But that's a minor thing. Most people are on fairly stable doses of levothyroxine and fairly stable doses of warfarin, and most people on warfarin are getting it checked very regularly anyway. So that's just something to look out for, though, if you're on that combination. And the third drug was contraceptive pill.
Yes.
So estrogens bind, or estrogens have an effect on the binding proteins for thyroid hormones in the blood. So nowadays we measure free thyroid hormones, free T4 in the blood, but in the old days, or strangely still in Denmark, if there's anyone from Denmark on the webinar, in Denmark all the biochemists still seem to measure total thyroid hormones in the blood. So women on the contraceptive pill, or pregnant women, because they have high estrogen levels, their total thyroid hormone levels in the blood tend to be higher, but the free thyroid hormone assays get rid of that. And so estrogen has a similar, if you like, binds more thyroid up in your blood, but that's normally, those effects are eradicated by our modern assays, which take that into account effectively by measuring free T4. So I think that's those three drugs dealt with.
Yeah. What about omeprazole? Linda asks if you have reflux, severe indigestion, and take omeprazole and thyroxine, what drug should she have to replace the omeprazole?
So that is a problematic question, and I've definitely seen that before.
Yeah.
I mean, you could try to go for an old-fashioned, a different acid-suppressing medication. So ranitidine, or nowadays ranitidine's not widely available, but famotidine is another so-called H2 receptor blocker, which has an effect like omeprazole, but it's not as, omeprazole is like it really switches all your acid off, whereas an H2 blocker may be enough to reduce the acid and still allow you to absorb some thyroxine. But the problem is, if you've got bad reflux, when you reduce these drugs, your reflux will become horrible. So it's a bit of a rock and a hard place, or it can be a bit of a rock and a hard place. But it may be, the advice is carry on your omeprazole and just take your thyroxine with some vitamin C at a time of day when your reflux is not bad. So generally first thing in the morning rather than last thing at night, because most people's reflux is bad when they lie down.
So it's advisable to separate them by a few hours.
Yeah, well, by as long as possible, yeah.
Yeah.
But the problem is omeprazole works for most people for 24 hours.
And then Ali asks about iron tablets. Can she take them in the evening without problems?
Yeah, so if you take your thyroxine first thing in the morning, it's absolutely fine to take your iron tablets after lunch, say, or in the evening. That's not a problem at all. Yeah. But as she says, it's definitely a bad idea to take your thyroxine at the same time as your iron tablets. That's going to be a problem. So,
did you want to carry on going through the advanced questions?
I'm just thinking, Shireen had a question about doctors campaigning for improved access to T3, and Jim had a really interesting question about T3, T4 as well. And I'm just wondering if actually, I've already been in touch with Jim via email, and he's happy for his question to be held over. I wonder if it makes sense to hold Shireen's over as well, or if you want to say something about that, Simon.
Well, I mean, I think the second part of my talk goes into this in quite a lot of detail.
Yeah.
I think if T3 worked for everyone with hypothyroidism and made them feel better, we'd be using it, and the NHS would have it freely available. But the trials don't really show that, and my next talk really goes into that in some detail. All I would say is I think there are reasons some people are finding it difficult to access, but because the evidence for it working isn't very strong, the objective evidence for it working isn't very strong for most people. And I don't want to really spoil my next talk, but because it contains a lot of detailed information about that. But yeah, is that a sufficient answer at the moment?
Yeah, no, I'll just say something else on top, but I think that's absolutely right to hold that discussion over to the next thing. So just to say to anybody who's sort of champing at the bit to know things about T3, there's lots of information on our website about what the NHS's position is, which is that they do say in their national guidance that if an endocrinologist thinks that you need T3, you should be prescribed it on the NHS. And we're really aware that there are lots of local clinical commissioning groups and being quite restrictive about not allowing doctors to prescribe it when they might want to. And there are lots of resources on our website that people can turn to, including sort of letters you can write to your MP and things. If it's something that's of interest to you personally, then please do have a look at our website and come back for the conversation on 15th of September and look at our information videos to learn more about this, because it's a huge, vast subject. So I think let's park it until then. Judith, you were collating the questions that had come in during the session.
Yes.
What do you want to do next?
I was going to suggest the next lot of questions, including one from Shireen, which I moved into this section, were on weight gain loss.
Yeah.
And Shireen asked, do you know how someone with hypothyroidism should or can lose weight easier? That's the $6 million question we all want to know.
So I mean, this is a problem for the whole population, not just people with hypothyroidism. Everyone has difficulty losing weight. A lot of people say, since I had hypothyroidism, I can't lose weight anymore. But you could also read into that the same thing that most of the population say, which is since I became 35 or since I became 40 or since I became 45 or 50, I can't lose weight anymore. And in my case, since I became 54, I can't lose weight anymore. So this is a really common thing. There are small effects of thyroid hormones on your weight. And one thing I'll tell you in the next talk is that the people who took the desiccated thyroid extract actually did lose a few pounds, but they didn't feel any better in that trial. So thyroid hormones do influence that, but it's a very small effect for most people. And I think to lose weight, people with thyroid problems just have to do what everyone else does, which is think of your diet as something that, the same as your dog's diet. It's just the food you eat every day. You don't go on a diet for a week or two. You choose a diet that's going to keep you at the weight you want for the whole of your life. So you need to make small adjustments that you can maintain forever to do that. And most people gain weight year on year. It's quite interesting that on average, the lockdown has been terrible. There's actually data showing that the average North American has gained a stone in weight over the last year.
A lot of people have.
I don't think there's no special thyroid diet. The advice is if you've been on a diet and you successfully lost weight on that before, that's the first place to start to lose weight. And the best diet is that works for you, and it's quite individuals. But these are all generic bits of advice and have little to do with your thyroid, because I don't see the trials of people with mild hypothyroidism when they've been given thyroxine show it doesn't change your weight. It's only if you have really profound hypothyroidism and had it for a long time that you can get significant weight loss by starting on levothyroxine. So if you had mild hypothyroidism, the trials don't show any benefit for your weight by getting treatment.
What about if you put on weight? Ali asks, should your dose be
Probably not. No. That means lots of people would be, as everyone, everyone has or so many people have weight management issues, that everyone will be over-treated with thyroxine if we were doing that. And that's not a good plan for lots of reasons.
Mm-hmm. So I'm scrolling through to a number of questions about blood tests.
Yeah.
Inevitably, there's going to be a lot of questions about these. So Mercedes asks, and this came up quite early in your talk, are you saying healthy according to blood tests?
Well, I think, one of the things I'll show you in the next talk is that if you blind people so they don't know what dose of thyroxine they're taking, as long as it's about right, they can't tell the difference. So some people feel they're very sensitive to small doses, small changes in thyroid hormone. I've seen many patients like that myself, and we try to adjust them by, going on 100 micrograms 2 days a week and 125 one day a week, and then like alternating patterns like that, and some people find a level that really suits them. But the problem is, if you get stuck on a different brand of medication, that all gets reset because the brands have subtle differences between them. So I think it's good practice to work with patients to achieve a sense of well-being. But one of the parts of thyroid bias is that most people believe they'll feel better when they're on a higher dose of thyroxine. Mm-hmm. And in fact, the blinded studies show people cannot tell what dose of thyroxine they're taking. If you give them 3 different doses of thyroxine sequentially and ask them which dose they felt better on, actually the bias slightly favors the lower dose, not the higher dose. So when this is done in a controlled fashion, people can't tell. And of course, that doesn't mean no one can tell. That just means on average, people can't tell.
That's interesting. Then there's several questions on whether to test T4 and T3. Pilly says they only do the TSH test in most GPs now. You've said that we should have TSH and T4.
Well, I kind of said something slightly different to that, actually. I think I think so the way this works is most laboratories run a cascade system. Mm-hmm. And the reason they do that is in Newcastle, the laboratory serves a population of, I think it's about 350,000 people live in our direct area. And every year they run more than 100,000 thyroid tests. That means about a third of the whole population are getting their thyroids bloods tested every year, and a third of the population don't have thyroid disease. So there's a lot of extra testing that is probably not necessary, and that's actually a big drain on NHS resources if people are being tested for no good reason. So one of the ways they can make that make sense of that is by having a cascade system, which is, unless you've got a pituitary problem, which is a small but significant consideration, then they measure your TSH. If your TSH is normal and a pituitary problem isn't suspected, then they won't measure anything else. If your TSH is high, they'll then go on to measure a free T4 to see whether you've got overt or subclinical hypothyroidism. And sometimes our laboratory will cascade into measuring antibodies as well, measuring thyroid peroxidase antibodies on that blood sample. And if your TSH is very low, less than 0.1, our lab will cascade to measuring free T4 and free T3 automatically, and thyroid stimulating TRAV antibodies to check for Graves' disease if it's the first time you've had blood tests like that. by using these cascades, it means the GP can't request specific blood tests very often, but if they're abnormal, the laboratory will automatically make the measurements. So not every lab, not every region runs the same system, but that's certainly in the north of England, that's a very common system, and I know it's the same in Scotland as well. Is most labs run a cascade system, so that your TSH is measured first, and if that's normal, not much else happens. But if it's abnormal, then you get the relevant test measured.
Well, one of our participants, Derek, actually pointed that out. The hospital labs won't test for T4 and T3 if the TSH is within the range. But going on to, I think it's quite an interesting question from Claire. She says, I was only ever tested once and then prescribed. The levels weren't way out. Would it be worthwhile coming off medication to check what the body is doing?
I would say so, yeah. I mean, I would always say, you should never start treatment for life on the basis of one blood test. It just doesn't make sense. As we know, 60% of the people in that Israeli study, their TSH value is normalized. So it's almost more likely to be a false positive result than you are to have the thyroid disease. So but particularly if you don't feel well on the thyroxine, I would stop it and have your TSH remeasured in 4 to 6 weeks and just see what happens.
Yep.
But unless you're pregnant, which you shouldn't do that if you're pregnant. But in every other situation, it's pretty simple to do.
Mm-hmm. There's another question from Mercedes who asks, does FT3 drop during illness?
So yes, so FT3 drops during almost every illness, and we believe, I mean, that this has been quite well studied in certain situations. So in patients with heart problems, because thyroid hormones help the heart contract, heart surgeons have thought, well, we know T3 drops after people have had heart surgery, and maybe that's one of the reasons that their hearts don't work as well. And maybe if we gave people T3 back in the few days after heart surgery, their hearts would pump better and we get better results. So trials like that have been done, and they don't show any benefits of so even after major heart surgery, your T3 levels plummet to your boots, and replacing the T3 in that situation doesn't help you. And that's probably because tissue T3 within the heart and within your brain and every other organ is probably just about okay in that situation, but there's not much in your blood.
Well, that's really interesting.
It's fascinating, isn't it?
There's a question from June. It is T3 related, but it does relate to blood testing. How do you know if the patient is taking adequate, too little, too much T3 if you never measure it?
Yeah, so I mean, this is a good question again. And one of the problems about T3 is we don't know even when to measure it in someone who's taking T3, but because you take your T3, if you're taking T3 only or not thyroxine, you wake up and you'll have very low levels of T4 and very low levels of T3 in your blood, and then you'll take your T3 and the levels will go probably higher than the normal range for 2 or 3 hours, then they'll drop to below the normal range for another few hours, then you'll take another T3 and they'll go up again. So we don't even know whether we should be measuring the pre-dose T3 level, the peak of the dose when your levels are going to be above the normal range, or 4 hours after taking tablet, or 6 hours after taking tablet, and because you're looking at a moving target in someone taking T3. So my recommendation is generally to not measure it, because it doesn't tell me much useful as long as the person is, unless I suspect the person's not taking T3, but I would still just go on the TSH in that case, because the TSH tells you whether the brain's getting enough thyroid hormone or not. And if the TSH is high, my temptation will be to increase the T3 or T4. And if the TSH is low, my temptation is going to be to reduce it, depending on the person's symptoms and exact circumstances. So measuring T3 because it's in and out of your blood so quickly, but of course not in and out of your brain so quickly. It stays in there for a lot longer than it stays in your blood. So that's the paradox. The blood T3 doesn't help you really very much in guiding T3 replacement. At least that's my experience of it, and that's because it's such a labile hormone.
Great. And when we come back in September, Jim's really interesting question about T3 in the brain and how you measure it and how meaningful blood tests are and where research should be going is it's going to be a great one to kick off with. I'm just noticing the time, Judith. It's 7:29, so I think we should probably wrap up unless there was any other burning questions still to be asked. I know there's still some outstanding, but we can't keep Simon forever. There's a football match on.
I think that a lot of the questions are T3 related, and we could hold those over till next time. I just wondered if you had time, Simon, to look at the questions on the hypo crossover.
So someone was saying, can you be hyperthyroid and then hypothyroid, or
yes.
the other way around?
Well, yeah. There's several questions. Is there a crossover of symptoms to start with?
Oh, I see. So well, the symptom questionnaires that Torquil made identify a series of symptoms that are commoner in hyperthyroid patients and a series of symptoms that are commoner in hypothyroid patients. But you might say there's an overlap of symptoms because people with both conditions can feel really, really tired. And also some people with hypothyroidism tend to feel a bit anxious, whereas most people feel that, or that's more of a consistent symptom, and mood disturbance with hyperthyroidism. Yeah. So there is an overlap, and it's not so rare for someone to go to their GP thinking I've got thyroid underactivity, and the GP measures the test and actually it's the opposite, they've got overactivity. So we certainly see a lot of that, you know. So symptoms can you know, be a bit mixed for sure. With regards, some people with Graves' disease actually start off hypothyroid, and they can be hypothyroid on thyroxine often for years, and then suddenly the GP measures the TSH and they say you need to reduce your thyroxine, and that goes on for 6 months, and then the GP says, well, maybe we should stop your thyroxine, and the person's still hypothyroid, and their Graves' disease antibodies have changed from blocking antibodies which stop your thyroid working to stimulating antibodies that cause, you know, hyperthyroidism. And so probably about 1 in 20, 1 in 15 to 1 in 20 patients with Graves' disease has had a hypothyroid prodrome before, if you like, before they actually go hypothyroid. So that's curious, and sometimes it's years and years and years.
And then perhaps we could just close with this one. Tyra asks, overtreatment can lead to hyperthyroid symptoms and possibly osteoporosis or atrial fibrillation. Is it the suppressed TSH that causes this, or do the overrange T4 and T3 cause this?
So that is a quite interesting question, actually, and has been a subject of some debate amongst endocrinologists. So I think the simple answer is it's the T4 and the T3, because the bone is quite sensitive to thyroid hormone levels, but there's an American researcher called Professor Zaidi from New York, and he also has shown quite nicely in mice that having fully suppressed TSH with normal thyroid hormones, you can manipulate a mouse in that situation. So just having the low TSH is enough to give you a degree of bone osteoporosis as well. So the truth is it's a mixture, but you should generally avoid being in the situation of having either high TSH or either high free thyroid hormones or fully suppressed TSH.
And
with that, I'll hand back to Lorraine.
Just quickly wrap up, just to say a huge thank you, Simon, for a very thoughtful presentation and lots of detailed thought-provoking answers to all of the questions, and your patience with us as well. Really very, very interesting session, and hugely looking forward to the 15th of September for part 2.
My pleasure.
Just like to say also thank you, Judith, for managing the questions, which was great, and also for hosting today's call on the Thyroid Cancer Alliance Zoom call, as you do for all the Thyroid Trust meetings, and it's hugely appreciated. Just like to also say thank you very much to everybody for coming, and for those of you who've been able to stay on for these extra few minutes. I hope it's been interesting and you've enjoyed it, and I hope you've learned something. I'm going to send you all the feedback form. Please fill it out. Please tell us what you liked and anything that you didn't like and that you might like us to do differently in future. And I'd just like to say also, several of you were kind enough to make a donation when you booked your place, and that's hugely appreciated. And if anybody would like to do so after the session, that would be hugely appreciated as well, because obviously times are difficult for small charities post-pandemic, and we can really do with all the support that anyone might be in a position to give us. And we are hugely, hugely grateful for those that do.